Hey, okay, so today we're going to be speaking about a safe examination for the post-traumatic neck, particularly when the symptoms are headache and any form of dizziness. Um, you cannot just go in there and start looking at range of motion. If there's a fracture here, which there can be, you can have a fractured, undisplaced fractured dens and walk around with it. You can have an atlantoaxial rotary fixation and walk around with it. So when you start moving this stuff around, you can displace the fracture or do damage to the subluxation and create fairly severe damage in the patient. At the same time, you can have things like VBI, for example, where again moving the neck may release an embolus. So your examination has to be sequential, and you need to keep your hands off their neck with no movement until you're sure that touching them and moving them is a safe thing to do. So we're going to be looking at a diagram, basically an algorithm that looks at going through each one of these possibilities of fracture, high cervical fractures and VBI before you actually start touching the neck, and what you can do if you start finding stuff that makes you want to send the patient out. Okay, so let's look at an examination process that will safeguard the patient from basically our interventions. This is a patient post-MVA or other trauma, come to that, with upper cervical pain, lightheadedness and posterior headache. So we're going to examine this as if these were serious conditions. We're going to try to eliminate them so we can get onto a more normal routine exam, as far as routine exams go. So we've got two major considerations here. One is potential high cervical fracture, where moving the patient can result in displacement of the fracture and serious injury. And the other one, of course, is a potential VBI problem, where again moving the neck may release an embolus and cause an injury. So the potential fracture is probably more dangerous than the potential VBI issue. So we'll go down that route first. And essentially, we're coming down this side of the screen. So we're looking at potential fracture, and we ask certain questions of ourselves on observing the patient and of the patient, and questions to the patient as well. So the first one, is there an obvious deformity here? Now, a torticollis isn't always benign. In this case, if this comes on suddenly and immediately at the time of the accident, then you've got a major disruption of healthy tissue here, or an unhealthy tissue, come to that, but it's a major disruption of tissue. Could be a fracture, it could be a fracture dislocation, it could be something like an atlantoaxial rotary fixation. So if you're seeing that, then you're probably better off not messing with it at all. Get them into an ambulance and straight off to the emergency room. If there is no deformity, your next question is, was there a sudden onset of the severest pain? And again, if there is that, then again, something has ruptured or broken. So it's could be bone, ligament, could be muscle, which is obviously not dangerous. If the answer to that is, it's a central tenderness, this means you've got to palpate, and this gets a bit iffy because if you palpate too hard, then they're likely to jerk away from you, and that's going to can produce problems. So if you're going to do that, make sure the head is well fixed before you start palpating. Better yet, don't palpate. That is not a good sign, and that should go to the ER as well. Again, quite possibly in an ambulance. Now, that's if the pain is central. If the pain is unilateral, anterior or posterior, this may be a more minor fracture, or it could be a torn muscle such as sternomastoid. On the other hand, that could also be a carotid artery injury, for example, and but that needs to go to the ER as well. But that's a different animal. There's not so much urgency with that as you might expect. So with careful palpation of the sternomastoid, if that isn't tender, then you have to worry about the underlying tissue, and I would strongly suggest that you don't palpate to see if the carotid is in trouble and tender. If the SCM is negative for palpation, you should get it to the emergency room. If the onset of pain wasn't sudden and it wasn't severe, then your next question is whether the Canadian C-spine rules breached. If the answer to that is no, then most probably this is not a fracture and you can move on to examining for VBI. If the answer to that is yes, then and an X-ray was taken, then again there's probably not a fracture, and that goes to the VBI exam. If on the other end the C-spine rules were breached, an X-ray wasn't taken, then it should have been, then you could do a cranial nerve exam and then send it to the MD. Probably not straight to the emergency room, and if you do, probably not by ambulance. This is given that it's breach of the C-spine rules and not one of the more severe signs and symptoms, you can probably not be quite so urgent with it. So if the potential for a fracture isn't present any longer, or is it significantly decreased, we can look at potential VBI problems. So do a cranial nerve exam. If the cranial nerve exam, and you can do that without moving the patient. And if you've got any concerns at all, put them in a collar while you're doing these exams. But you do a cranial nerve. If the cranial nerve exam is positive, it may well not be a VBI problem, but you should get it to the ER or the MD, depending on how urgent you think this is, to find out why they've got a cranial nerve injury. If the cranial nerve examination is negative, it doesn't mean to say that you do not have a VBI problem, because that cranial nerve may only become positive when they're symptomatic. So you have to ask them the questions about the dizziness and the headache and the neck pain. Are they coupled together, or can you uncouple them? Now, if you can't uncouple them, then you have to be concerned about this, particularly if the headache and the dizziness are coupled together, but both are uncoupled from the neck pain. There's not a good explanation for those two things, so that does need to go to the ER, again, the MD, if you don't think it's particularly urgent. If all three are coupled together, then it may be that all of it's coming from the neck, and then you have to start doing a little bit of physical testing here by stressing the joints without moving the joints of the neck. And if that doesn't produce a headache and or the dizziness, you should get that out of there. Anyway, if the dizziness and headache are unlinked or are linked together but also linked with the neck, and you're quite happy with your non-movement stress test for the neck, then you can move on a little bit more, start looking at your reproduction and differentiation tests. If they're positive, and remember that we're saying they're positive because the cranial nerve exam is positive, or they're getting hard neurological symptoms, then it goes to the emergency room or the MD. If not, it's probably not VBI, and you need to diagnose why they've got the headache, why they've got the dizziness, and is it all spondylogenic. So this way you don't move the neck at all until you're comfortable that moving the neck, which is going to occur way down here after all of this, it's going to occur way down there, and you're comfortable now that you can start moving the neck relatively safely. I would strongly suggest you consider looking at a post-traumatic neck pain patient with those symptoms in this manner.